systems level perspective on this one. I think there are a lot of policy opportunities related to the waiver in terms of case management, in addition to different requirements in the terms and conditions, not to get too kind of policy wonk here, but in the terms and conditions of the waiver with regard to how we are expected to interact with our local mental health plan, the Department of Mental Health here in Los Angeles County. So I think that we are articulating expectations kind of in our contracts and our provider manual that will be coming soon to kind of to outline to providers the sort of connections they have to make, right? And in addition to that, the state has said you must have an MOU that makes explicit the different kind of requirements that you are placing on your providers to make sure care is coordinated, such that if you encounter someone with a co-occurring mental health condition in your substance use disorder service network, you're ensuring that they get the care that they need within that network. So a couple of things related to that. So specifically to your point, Patricia, or your question about training, we have a contract with the California Institute for Behavioral Health Solutions, and there are a variety of different clinical and business trainings that we are launching through them, and will be ongoing throughout the life of the waiver. And I do think this is one area where we could do a good bit of work to make sure that our case managers and other clinicians within the network who need some more mental health training could get that. And so that's one opportunity. I think in addition, from a contracting strategy, we are very explicitly engaging the legal entities or contracted community providers within the Department of Mental Health network to become SUD providers through DMCODS and our network. So we have more overlapping networks in alignment, sort of alike what John and Vika were talking about during their presentations. And so in that sense, if we can have co-located services or integrated services within provider sites who can do both, I think that would also be fantastic. But those are just a couple of things that we're explicitly trying to focus on with regard to people with co-occurring conditions. And I think one last thing related to that that we're working on, also in collaboration with our criminal justice partners, is how do we have a meaningful, coordinated contracting strategy with mental health to develop a true network of providers who can offer services for people with co-occurring conditions. Because we know that these two conditions frequently co-occur, and we don't, at this point, I think, have an adequate sub-network within our broader SUD services network in the community to deliver those kind of services. And if we don't have the right kind of staffing and the right kind of payment structure, I think really the patient will suffer. And we just want to make sure that people are getting the services in the way that they need them.
So it's one of the advantages I spoke of earlier in terms of the team-based care. It means we're adding, really beefing up the number of licensed mental health professionals who are in our system, because there's a way to wrap that into the payment. And the whole notion of the team-based care is that there's a greater level of clinical supervision and cross-learning between the AOD counselors and the mental health professionals. That was really the intent behind it, that they can learn from each other and we can strengthen some of the assessment, like the assessment-driven care. You know, earlier I said we had individualized treatment plans, but not necessarily individualized treatment, and so that's really the intent of that. The other thing is we were, early on Health Right 360 has separately a specialty mental health contract, and we thought we would have to essentially, we wouldn't be able to provide that the mental health people inside the substance use programs were now responsible for that care, and the county made clear, no, to the degree you have seriously mentally ill people in co-occurring treatment in your facilities, and that they are getting specialty mental health care from the specialty mental health plan, that continues. It's not eliminated just because the substance use disorder benefit has been enhanced.